Welcome to Section 7 of the Renal Physiology Review. In Section 7, we will go into more detail of proximal tubular function, including an introduction to proximal tubular pathology, such as renal tubular acidoses and the Fanconi syndrome. Welcome to Section 7 of the Renal Physiology Review. In Section 7, we will delve into more detail into proximal tubular reabsorption, with a special focus on the reabsorption of bicarbonate. Also, we will introduce some pathologic states of the proximal tubule, where one can see the clinical manifestations of proximal tubular dysfunction. The diagram shown here is similar to one you will be asked on your step exam, so let's walk through it. As we said, about 2/3 of the total filtrate is reabsorbed in the proximal tubule. However, reclamation of filtered components is not uniform. Substances such as amino acids, glucose, lactate are almost completely reabsorbed. While we said approximately 2/3 of sodium is reabsorbed in an isoosmotic fashion. Finally, bicarbonate is primarily reabsorbed in the proximal tubule. Let's walk into a little more detail in this diagram. First, orient yourself. The x-axis is as you move along the proximal convoluted tubule. The y-axis is the ratio of the concentration of the substance in the tubular fluid versus the plasma. In the beginning of the proximal tubule, everything starts out the same in a 1:1 ratio. Anything that is freely filtered is going to be this way. As you move along the proximal convoluted tubule, you can see how a substance behaves. Substances that are primarily reabsorbed in the proximal tubule, their concentration will fall as you move along the proximal convoluted tubule. However, substances that are not as well reabsorbed in the proximal tubule, you'll see that their concentration in the tubular fluid will increase. The examples are given in the graph. Chloride reabsorption is low in the proximal tubule. This is because sodium reabsorption must be coupled with an anion, but the predominant anion in the proximal tubular reabsorption is bicarbonate. Therefore, the chloride concentration actually increases. While no chloride has been added, more water has been reabsorbed, so the total concentration of chloride has increased. Sodium reabsorption, while predominates in the proximal nephron, occurs in an isoosmotic fashion. This is why the sodium concentration in the tubular fluid remains the same as the sodium concentration in the plasma. The other substances are substances that are all reabsorbed coupled with sodium. The first one denoted is phosphate, abbreviated by PI. Phosphate reabsorption is also coupled to sodium reabsorption and primarily occurs in the proximal nephron. This is why, as you move along the proximal nephron, the concentration of phosphate in the tubular fluid goes down relative to plasma. In an increasing fashion, bicarbonate, glucose, lactate, and amino acids are reabsorbed in the proximal convoluted tubule, so that substances such as glucose and amino acids should not be present in the filtrate beyond the proximal tubule, unless pathologic states exist. It is important to walk through and practice these diagrams. As I said, they will be asked on your Step 1 exam. Much of the reabsorption of the substances previously mentioned are coupled to sodium reabsorption via the concept of secondary active transport. Because on the basolateral side of the tubular epithelial cells, the sodium-potassium ATPase is highly active, intracellular sodium concentrations remain low. This creates an environment promoting sodium reabsorption. Other substances, such as phosphate, glucose, amino acids, use this energy gradient, and their reabsorption is coupled with sodium. Remember, this all depends on the function of the sodium-potassium ATPase. Just a brief review of the sodium-potassium ATPase. It is the most ubiquitous transporter. It is present in all cells of the body. It is found in the basolateral membrane of the epithelial cells lining all the nephron segments, and it maintains the electrochemical gradient necessary to facilitate reabsorption of substances. 3 sodium ions are transported out, 2 potassium ions are transported in. This is an energy-dependent process. The net result is a very low intracellular sodium concentration, which promotes sodium reabsorption. Also, the net export of a positive charge creates a negative intracellular potential, which also promotes sodium and other cationic reabsorption. This gradient is exploited throughout the nephron, and it drives essentially all of the transport that occurs in the tubular epithelial cells. Reabsorption via secondary active transport is either directly or indirectly coupled. With respect to glucose, amino acids, phosphate, and other substances, reabsorption is directly coupled with the sodium, phosphate, amino acid, or glucose cotransporter. Substances such as bicarbonate, as well as uric acid, rely on indirect coupling. We will walk through the reabsorption of bicarbonate in more detail in a few moments. Once again, to tie in the other concept we've previously reviewed, intravascular volume depletion stimulates renin release and angiotensin II activity, as well as increased activity of catecholamines such as norepinephrine and epinephrine. These substances, while they also have effects on glomerular filtration, directly stimulate sodium reabsorption to expand intravascular volume. There's also then enhanced reabsorption of the other solutes that are reabsorbed with sodium. The proximal tubular reabsorption of bicarbonate, as I said, is indirectly coupled and driven by sodium reabsorption. We will walk through this in great detail. However, the detail is not as important for your Step 1 exam. Nevertheless, we want to give you an overview of the concept. We said that sodium reabsorption is driven by the sodium-potassium ATPase. Bicarbonate reabsorption requires the activity of the enzyme carbonic anhydrase. Bicarbonate cannot be reabsorbed in its charged form. It must pass through the cell membrane in the form of carbon dioxide. Carbon dioxide is formed when a bicarbonate ion is coupled with a hydrogen ion. The hydrogen ion comes from the sodium-hydrogen antiporter. Sodium is reabsorbed, hydrogen is secreted out of the intracellular space into the tubular lumen. This hydrogen then combines with bicarbonate to form carbonic acid. This reaction is facilitated by the enzyme carbonic anhydrase. Carbonic acid then dissociates into water and carbon dioxide. Carbon dioxide can be actively reabsorbed into the intracellular space. Although the hydrogen and not bicarbonate is physically pumped across the membrane, the result is a net reabsorption of filtered bicarbonate. What is important to remember is that a bicarbonate reabsorption and hydrogen secretion are essentially saying the same thing. For each bicarbonate reabsorbed, a hydrogen is secreted, and vice versa. In a little bit more detail, as we said, the intracellular sodium concentration is low due to the sodium-potassium ATPase. One of the essential transporters in the reabsorption of sodium is a sodium-hydrogen exchanger. This sits on the luminal surface of the tubular epithelial cells. The hydrogen is secreted into the tubular lumen, combines with bicarbonate to form carbonic acid. This reaction is greatly facilitated by the enzyme carbonic anhydrase. The CO2 is produced, which diffuses into the cell. Once again, there is another intracellular carbonic anhydrase in the cell, which catalyzes the reverse reaction. Bicarbonate is then free, and a sodium bicarbonate cotransport exists on the basolateral side of the tubular epithelial cells. This is how bicarbonate is then reabsorbed back into the peritubular capillaries and into the bloodstream. The hydrogen created from that reaction is recycled through the sodium-hydrogen exchanger. Thus, one can see how, in the absence of carbonic anhydrous activity, or in the absence of the sodium-hydrogen exchange activity, bicarbonate reabsorption would not be possible. The take-home points are as follows. Bicarbonate reabsorption is indirectly coupled to sodium reabsorption, and it requires the activity of carbonic anhydrase. Therefore, if either of these two processes are inhibited or dysfunctional, bicarbonate reabsorption will not occur. The last important point to remember is that reabsorption of bicarbonate essentially also means secretion of hydrogen. The two are always coupled. Let's talk about a few clinical correlates. Each of these are diseases related to proximal tubular dysfunction. Based on your understanding of proximal tubular physiology, one can predict what we would see. The four diseases we will overview are Hartnup disease, cystinuria, Fanconi syndrome, and a subset, type 2 renal tubular acidosis. Aminoaciduria is the excessive urinary loss of amino acids and occurs in two major diseases, Hartnup disease, which is a loss of neutral amino acids, and cystinuria, which is a loss of a cationic or basic amino acid. Both diseases occur due to impaired reabsorption in the proximal tubule. These are inherited as proximal recessive disorders and are primarily seen as pediatric disorders, although cystinuria, depending on the severity, can also present in adulthood. As we said, amino acid transport is coupled to sodium reabsorption. However, each of these has specific transporters that allows them to be reabsorbed. When there are defects in these luminal transport proteins, the amino acids cannot be reabsorbed, and the amino acids then pass through the urine and end up in the final urine composition. It's important to remember that the proximal tubule alone has the capacity to reabsorb amino acids. If the amino acids pass through the proximal tubule, they cannot be reabsorbed and will end up in the urine. Hartnup disease is an autosomal recessive inherited disease. There is impaired transport both in the renal tubules and in the small intestine of tryptophan and other neutral amino acids, such as valine, leucine, histidine, etc. What this results is impaired intestinal reabsorption as well as aminoaciduria. Because of the defects in transport, amino acids are retained within the intestinal lumen. Bacteria that is present in the intestine can break down these amino acids and form substances that are toxic to the central nervous system, which are reabsorbed. This is one of the clinical manifestations of Hartnup disease. The other clinical manifestation is due to the deficiency of tryptophan. Tryptophan is a precursor of niacin. When niacin deficiency occurs, there is a skin manifestation of photosensitivity as well as pellagra. Most patients are asymptomatic. However, because of the defects in tryptophan or the reabsorption of toxic compounds from the intestine, one can see skin manifestations as well as central nervous system manifestations. Also, there will be aminoaciduria because of impaired renal reabsorption. Cystinuria is also a defect of amino acid transport. There is both impaired intestinal and renal absorption of cysteine and other dibasic amino acids. The cysteine concentration in the urine predisposes to the formation of cysteine stones, which is the primary clinical manifestation of cystinuria. The diagnosis is made by urine microscopy, which shows these flat, colorless hexagonal crystals shown in this picture, which tend to aggregate together. The diagnosis is then confirmed by a 24-hour urine collection to measure cysteine levels, which will be much, much higher than what should be expected. Perhaps the prototypical example of proximal tubular dysfunction is Fanconi syndrome. Fanconi syndrome is a distinct phenomenon from Fanconi anemia, completely unrelated outside of the individual who discovered the syndromes. The pathophysiology is generalized dysfunction of proximal tubule cells. This can occur from a variety of reasons, including drug toxicity, disease multiple myeloma, and inherited disorders. The clinical manifestation is impaired reabsorption of multiple substances, glucose, amino acids, phosphates, and bicarbonate. Therefore, all of these substances will be present in the final urine at much higher concentrations than they should be. Essentially, you will see glucoseuria, amino aciduria, phosphaturia leading to low serum phosphate concentrations, and bicarbonaturia leading to a metabolic acidosis, or a low serum bicarbonate concentration. The generalized proximal tubular dysfunction leads to impaired sodium reabsorption as well. This manifests as urinary solute loss, which leads to osmotic diuresis. Initially, the symptoms will be polyuria, polydipsia, and volume depletion from the impaired ability to reabsorb. There are also multiple metabolic abnormalities that can be easily observed with a basic serum chemistry panel. Because of the impaired reabsorption of phosphate, serum concentrations of phosphate will be low. Because of the impaired reabsorption of bicarbonate, serum concentration of bicarbonate will be low, manifesting as a metabolic acidosis. There are also indirect effects of the osmotic diuresis. Because of volume depletion, the renin-angiotensin-aldosterone axis is stimulated, so there is increased sodium reabsorption distally. However, this comes at the expense of increased potassium losses. There is also increased calcium losses because of calcium buffering from bone in response to the metabolic acidosis. The calcium loss then can lead to bone disease and, at extreme levels, hypocalcemia. One of the primary manifestations of the Fanconi syndrome may be the bone defects themselves. Especially in children, the manifestation may be growth impairment and failure to thrive. The bone defects result from multiple mechanisms. The metabolic acidosis, which promotes buffering of the acid load from bone, the hypophosphatemia, which is necessary for normal bone mineral formation, as well as the urinary calcium loss. Type 2, or proximal RTA, is essentially dysfunction of the proximal convoluted tubules, indirect coupling of sodium and bicarbonate reabsorption. We've outlined before how bicarbonate is reabsorbed, but let us simply review. Sodium reabsorption occurs through a sodium-hydrogen exchanger. The hydrogen secreted then couples with bicarbonate, converts into carbon dioxide, which then diffuses into the cell, goes through the reverse reaction, and then sodium bicarbonate is reabsorbed on the basolateral segment. Impairment in any of these steps, the sodium-hydrogen exchanger, carbonic anhydrase, or the sodium bicarbonate basolateral reabsorption process, results in increased bicarbonate losses. Increased bicarbonate losses will look similar to the Fanconi syndrome, giving low serum bicarbonate concentrations and a metabolic acidosis. Proximal RTA refers to simply the failure of bicarbonate reabsorption. Most often, the proximal RTA clinically exists in the setting of a Fanconi syndrome, with the other manifestations outlined previously, including glucoseuria, phosphaturia, and amino aciduria. The other major cause of proximal tubular acidosis is with the administration of drugs, specifically a carbonic anhydrase inhibitor. Carbonic anhydrase inhibitors are used as diuretics, as they inhibit sodium reabsorption. The other result of this, however, is increased bicarbonate losses from impaired bicarbonate reabsorption. We will go into more detail about carbonic anhydrase inhibitors in the diuretic section of this review. Some of the other functions of the proximal tubule include hormonal functions, as well as the major site of ammonia synthesis. The proximal tubule is the major site of activation of vitamin D. where vitamin D exists in the inactive form of the 25-hydroxy state. It must be hydroxylated to 1,25-hydroxyvitamin D, or calcitriol, to be active. This process occurs primarily in the renal proximal tubule. The other major component of proximal tubular function is ammonia synthesis. Ammonia is the primary buffer in the tubular fluid that is highly regulated. Ammonia secreted into the renal tubular lumen can be protonated and excreted in the form of ammonium. Ammoniogenesis and the secretion of ammonium is one of the primary means of increased acidification of the urine. If ammoniogenesis is impaired, urinary acid excretion falls drastically, and the end result is a metabolic acidosis. Let's walk through a few questions. The secretion of hydrogen ion in the proximal tubule is primarily associated with which of the following? Secretion of potassium ion, secretion of hydrogen ion, reabsorption of bicarbonate ion, reabsorption of calcium ion, and reabsorption of chloride ion. The correct answer is C, reabsorption of bicarbonate. As we said before, hydrogen secretion is always coupled with bicarbonate reabsorption. They are essentially one and the same. Also important to remember is that the secretion of hydrogen is coupled with sodium reabsorption. Question 7. Which of the following solutes will be more concentrated at the end of the proximal tubule than at the beginning of the proximal tubule? A. Sodium, B. Glucose, C. Bicarbonate, D. Creatinine, E. Phosphate. The correct answer is D. Creatinine. This question is similar to the graph we walked through comparing the tubular fluid concentration to the plasma concentration along the proximal nephron. One can recall that substances are reabsorbed in a preferential fashion in the proximal tubule, primarily glucose, bicarbonate, and phosphate. Therefore, their concentrations will be lower at the end of the proximal tubule than at the beginning of the proximal tubule. The answer thus must be D, creatinine. While sodium reabsorption primarily occurs in the proximal tubule, sodium reabsorption occurs in the isoosmotic fashion. Therefore, the sodium concentration will be the same at the end of the proximal tubule as at the beginning of the proximal tubule. This concludes Section 7 of the Renal Physiology Review. The key point to remember from Section 7 is that the proximal tubule is a high-capacity, low-energy reabsorption mechanism, where most of the sodium and water that is filtered is reabsorbed. The other ions and substances reabsorbed are primarily coupled with sodium reabsorption.